So my name's Randal Faull. I'm chairing this afternoon's Adelaide Biomedical City Research Minireview webinar. And welcome to those of you who have joined. And we've got two speakers this afternoon in the area of renal disease. The first speaker is Professor Toby Coates, who will be speaking on recycling pancreatic islets in hereditary pancreatitis, preventing cancer, relieving pain and preventing diabetes. The second speaker is Associate Professor Shilpa Jesudason, and I'll introduce her topic when it's her turn to speak. For those of you who've done this before would be familiar, but if you haven't joined before, we're very happy to take questions at the end of each of the presentations. If you type the questions into the Q&A section of your Zoom window, and I'll be responsible for asking the speakers these questions. And also remind you that the session is being recorded and will be available on the Adelaide Biomedical ABMC website. So great pleasure to introduce one of my colleagues, Professor Toby Coates, who's going to be talking about one of the many areas he's passionate about. So Toby, please get started.
Great, thanks Randal. I'll just share the screen. Renal research that we're involved with, or I'm involved with here at the Royal Adelaide in Biomedical City, as you say. So we perform a lot of transplant procedures, and what we currently able to do are kidney transplants, and I'm delighted to say that we passed our 3,000th kidney transplant earlier this year. We do simultaneous kidney pancreas transplants, which are steroid-free. That's unique in Australia, and we just did our 10th one of those this last weekend. We also do islet allo transplants, which are treatment for type 1 diabetes, and that's a nationally funded centre program. And we do this other procedure, which is currently not funded, but is the basis of my upcoming MRFF grant, which is the total pancreatectomy and islet auto transplant. And that's what I want to share with you today. So Jane Doyle actually gives probably the best introduction to this.
An Adelaide boy's undergone an Australian first transplant. 7-year-old Gary Wanganeen suffered from hereditary pancreatitis and had to rely on strong painkillers until his mum found the surgery on a Facebook forum. His pancreas was removed and sent to Melbourne, where islets were extracted, the cells were returned to Adelaide and infused into his liver the same day. So
that, in essence, is what a total pancreatectomy and islet auto transplant is. So we could spend a long time talking about pancreatitis. It's a chronic condition, and we've got some really interesting new data that's being generated and hopefully be able to share with you shortly on the cost and exactly clinical manifestations of this condition. But it occurs if you have it lasts more than 6 months, and it has many painful features to it. The condition that I'm particularly interested in are the genetic ones, and these are the ones that affect very young children like Gary, as you just saw. And what's interesting about it is that many of the processes that are going on in the pancreas are very, very similar to what we see in particular in a rejecting kidney transplant. So when I started to get interested in this, it was a little bit like looking at the same organ, but in a slightly, same processes in a slightly different organ. On all of the things that I'm interested in particular, the immunology of the chronically inflamed pancreas contain many of the players that we see when we're looking in the kidney transplant. The gene that causes most of the problem, and the gene that Gary's got, is a little gene called PRSS1. And what's important about this gene is this basically makes the pancreas increase its production of trypsinogen and start to digest itself. And you can imagine that would be an extremely painful process to undergo. So we got interested in this, and we've discovered that we have quite a high prevalence of this these sort of genes in the South Australian population. And here's just one family which has got 14 affected individuals and 2 early pancreatic cancer deaths. And we know that in this condition, if you get this, the chance of getting cancer is significantly accumulated. And by the time you reach 75, it's very similar risk if you've got this gene to what you might have if you had the BRCA1 cancer-related gene. And we know that survival for these patients at 5 years is extremely poor. And it's certainly a huge burden for the patients, their families, and society as a whole. This is what a normal pancreas looks like in the middle. And on either side here, you can see a chronically scarred pancreatitis pancreas. And what I want to point out to you here is these are the pancreatic islets, the cells that I've been interested in transplanting for a long time. And you can see that they're actually very well preserved, even despite the damage from the chronic pancreas. And so that's led to this concept of being able to...
The key advance here is the ability for us to remove the pancreas and isolate the islets from the diseased pancreas. We can put them into the liver through the portal vein so that the liver will make the insulin that the body needs.
So having done little Gary, we moved on to start to study this. And this is an honour student of mine, Deng Hao Wu. I'll very quickly show you here's some of his data and what he's generated. Essentially, he's found now a cohort of 91 individuals who've got this particular gene within South Australia. And what I want to draw your attention to here, in the rest of the world, the frequency of this gene is between 0.1 and 0.57 per 100,000. On the basis of Deng Hao's study, it looks like in South Australia, we've got something like 5 per 100,000 people with the gene, and up to a third of these are First Nations people getting pancreatitis at a very early age. So something's very much going on here. Here's a second honours student of mine. This is Tristan Bampton. He's just collected the series of our patients who've undergone the total pancreatectomies and islet auto transplants. South Australia leads the way here. We've done 11 of the 16, and Westmead have done the remaining 5. And what I just want to point out very quickly is this is a very effective procedure in terms of treating the pain and getting people off opiates. And you can see here 13 out of 16 on regular opiates. And after this procedure, that gets down to 1. What about in terms of hospital admissions? This is data that came through literally this afternoon. This is a subset of our patients, and you can see the hospital admissions and ED attendances before and over here after the total pancreatectomy and islet auto transplant. So it's effective at relieving pain. It's effective at improving quality of life and reducing hospital attendances. So where we're going is we've got a plan to have our own biospherics chamber, which is a machine that helps us isolate the islets here. It's been greatly supported by the Hospital Research Foundation, and it's the basis of our MRFF grant, which is going in next week, and what I'm working on at the moment. And it's going to be to fund a trial, which is going to be called the HEPATA trial, which is the Hereditary Pancreatitis and Auto Islet Transplant trial in Australia. And the idea will be to do genetics, whole exome sequencing, establish a registry here in South Australia to track these patients, and then perform these pancreatectomies in up to 30 patients over the next 5 years, and provide some very interesting molecular analysis. So I thought what I'd do is now just very quickly in the last minute, show you the impact on an individual.
If I were to describe pancreatitis in one word, it would be excruciating. That's the pain of pancreatitis. My name's Chelsea Holloway, and at age 11, I was diagnosed with hereditary pancreatitis. Pancreatitis is a condition where your pancreas decides to initially pack up on you and become extremely inflamed. So at age 11, when I was initially diagnosed, I was told that there is nothing possible to fix my problem. I had to last with that thought until at least, 16 and a half, 17 years old. I would be taking 5 to 6 oxycodones and tramadol daily just to function as a normal person. I was constantly missing out on school, missing work, trying to hang out with my friends was impossible because I was always too unwell. It was around 16, 17 years old when I met Toby, and we started the process for the total pancreatectomy auto islet transplant. I was in an induced coma for a few days in ICU, getting out of hospital, recovering quite well, which leads me to my life now. I work full time, don't have to have time off. I play in the Premier League netball squad. I can hang out with my friends and family as much or as little as I want to. I'm never in pain. I'm completely saved by this surgery. Pancreatitis in my family is hereditary. It comes from my mum's side of the family. If Toby can support me and change my life as much as he has, I'm so excited to see what he can do for others, especially my family in the future.
In the final slide is really to acknowledge the people that do the work as opposed to the people who just talk about it, which is me. And these are all the people that have contributed to this program and supported by JDRF and really the Hospital Research Foundation, which has enabled us to do the total pancreatectomies and hopefully position ourselves to be the leading centre in Australia and I hope in Asia that provides this rare treatment for these patients. So I will stop that right now and hand it back to you, Randal.
Okay, thanks, Toby. So if there's any questions, please type the questions in. But to get started, Toby, can you talk a little bit about the role of the surgeons in this particular procedure?
Absolutely. This is very much a surgically driven procedure, and John Chen and Yuling Neo and Sanjeev Khurana are the three surgeons that perform the pancreatectomies. They then, with our transplant surgeon, Chris Russell, the pancreas is then packed and then shipped off to Melbourne. So it's very much dependent on surgical expertise. And the islet isolation component of this is done in Melbourne at the moment, but hopefully, as I mentioned, we'll get to the point where we'll be able to do that here independently with Chris Drogamel, or our islet scientist who's been involved with all of the cases that we've actually done. So this is in increasing capacity for what we can do within the state through this particular type of research. Right?
And you'll be planning to involve some of the genetics team researchers in this in the future as well?
Yep. So the MRFF grant covers essentially genetic diagnosis. If Deng Hao's numbers are correct, then I think we might be able to find up to 500 that we could readily enroll in this study. If the 5 per 100,000 translates through to the rest of the country, then it's probably about 1,200 people. And I can readily believe that, because a small subset of these end up in hospital, and the rest of people, once they've got this diagnosis, tend to stay at home and not present to hospital for fear of being labelled as analgesic seekers. And the other really important point that's on the second to last slide there is the high prevalence of First Nations people. Up to a third of the people that we've identified in our without even trying, in our 91 have Aboriginal and Torres Strait Islander background. And you can readily appreciate that if you have that if you had this gene and you presented with pancreatitis, you might well not be thought to have a genetic cause, but other factors might well be ascribed, rather than thinking outside the box.
So we've got another question from one of the audience, Toby. The question is, what has been the impact of COVID in Victoria on the islet transplants?
It's stopped them completely, and that's because we haven't been able to either ship pancreases across to Melbourne to be isolated, or indeed for islets to come from Melbourne to Adelaide. So we'll be hoping that Victoria opens up as quickly as possible.
Okay. So I think that's the last of the questions so far. So maybe we'll move on then to the next speaker. But thank you, Toby. Thank you for that. And I'm sure people will know how to contact you if they want to ask further questions, and they can also look at the webinar. All right, so the next presenter is Associate Professor Shilpa Jesudason, who's going to talk about some of the clinical research that we've been doing in CNARTS, which is broadly the renal department at the Royal Adelaide Hospital, but involves Lyell McEwin Hospital as well. So welcome, Shilpa.
Thanks, Randal. I'll just share my screen. So I thought I'd give an overview of, some of the, a number of the projects that are happening in CNARTS under the banner of clinical research, and then focus in on one particular project and really show you the genesis of that and how it's kind of grown from patient need and from the coalface up. So CNARTS is the largest renal service in South Australia, and we have a very broad-ranging service. We have a very captive patient cohort of over 700 dialysis patients, both in centre and in satellite units, in home therapies, and also a nocturnal dialysis program. As Toby has already mentioned, we are a major transplant centre, and not just kidney transplants now, but thanks to his programs, pancreas and islet transplants, as you've just seen. We have very strong connections with Indigenous renal services. We're the transplant centre for the Northern Territory, and also have a number of country sites that service the Indigenous renal population as well. And so we're really broadly spread all over the state, and as I said, with a very well-defined patient cohort, which lends itself to research that is patient-centred. So the clinical research that is done within the unit broadly falls into three umbrellas. And I'll talk a bit more about the CNARTS Clinical Research Group, which I chair, in a moment. But we also have a very active clinical trials unit. and at any given time there's at least 30 or so clinical trials in chronic kidney disease, diabetic kidney disease, transplantation, glomerulonephritis that's running in the unit. And we have quite an active trials staff group that help us run all of these trials. And really this trials unit has helped us bring a number of novel therapies and new drugs into our service. And South Australian renal patients have historically been the first to get access to some of these new therapies because of our activity in clinical trials. And these are not just industry-led trials, but increasingly we're doing investigator-led trials, particularly through the Australasian Kidney Trials Network. So that's the trials unit. And then the Australian New Zealand Dialysis and Transplant Registry, which is an international registry, is actually based at Samari and grew from the original renal unit at the Queen Elizabeth and is very much wedded to the CNARTS renal service. And Stephen McDonald and Phil Clayton from our unit are leaders within that registry on behalf of the nephrology community. So a lot of activity happening, and if you want to learn more, we do put out an annual research report. Our 2019 one has just been published. You can find it on the Royal Adelaide Hospital Research Fund website, or you can contact me and I can pass that on to you. So the clinical research group that I chair was established in 2015, and it really came out of seeing this need to enhance the various collaborations between medical, nursing and allied health research that was going on in the unit. It wasn't particularly coordinated or cohesive, and we felt that we were stronger together. And so really trying to bring that research under one umbrella, we wanted to provide a forum for sharing of knowledge and sharing of research expertise and mentoring staff within the unit, staff, students, trainees who wanted to start with some research but didn't know where to start. And in particular wanting to provide guidance for researchers at all stages of their research career. And the idea was to really work with clinicians and staff who are at the coalface of care for patients with kidney disease and try and embed a culture of research into our unit. And this research group also provides a framework for research governance within CNARTS around tracking research activity, assisting with ethics, financial management and general governance over projects. So the kind of work that we're doing in the clinical research group is really focused on patient-centred research that is going to lead to some sort of clinical practice change, either within the unit or more broadly. And this includes a focus on patients who are transitioning to dialysis, which we recognise as a really vulnerable time, particularly their symptom burden and psychosocial distress that they may experience. And I'll talk a little bit more about the needle distress and fear study that we're doing as a case in point. We're also doing some work around integrating primary care into our renal service. We have a very strong Indigenous research program that is focused on changing models of kidney care for First Nations people, and this is underpinned by a very strong community partnership with the Action Aboriginal Reference Group, and that's been a very fruitful collaboration that's led to some direct clinical service changes. And then there's a whole host of other activities that we're doing around gut health, around exercise and physical functioning, pharmacology. We have a program of diversional art therapy in our dialysis units, and we've got a large program looking at parenthood and pregnancy in patients with kidney disease, which is my particular research interest. And I guess the key thing to mention here is that many of these projects are underpinned by very strong consumer engagement and actually have patient partners involved in the design and conduct of these research projects. We've actually been involved in a national initiative to improve consumer engagement in nephrology research across the country and in scientific conferences as well, and that's been a very successful initiative. So this is all not just us doing it on our own. We have a very extensive range of collaborations with groups right across the Adelaide Biomed City precinct. And you can see here I've listed some of the groups that we're collaborating with at the RA, at University of Adelaide, at UniSA, and over at SAMRI. And I guess the key thing is that we're now co-designing projects that involve members from all of these different areas. We've had some grant success. We've now got higher degree by research students, honours, masters and PhD students coming through. And we've also managed to really engage our clinical staff in research. Even staff who would not have thought to get involved in research are now becoming part of our research program, which I think is a really exciting change within the renal unit. So I just wanted to talk about the INJECT study, which is improving management of needle distress during the journey to dialysis through psychological education and training, much more easily said as the INJECT study. So for patients who are receiving hemodialysis as a life-saving and life-sustaining treatment, if they're dialysing through an arteriovenous fistula, they need to have 2 large bore needles put into their arms. They have 3 dialysis sessions a week. So this equates to 312 needles a year just to maintain life. And if you're a patient who has a fear of needles, this can be a really distressing thing to have to go through, but you have no choice because this is your life-saving therapy. So we have undertaken a collaboration with RA Clinical Psychology and the University of Adelaide Psychology and UniSA Nursing to pull together the INJECT study, which is designed to try and address this issue. And the way this came about is we started with another study that we've done in the unit, which was a 12-month prospective cohort study of patients who were starting dialysis, and we were capturing their patient-reported outcome measures, 179 different measures, over 3 time points when they started dialysis. And the only thing that we didn't measure in those validated tools was fear of needles. But we conducted some focus groups and interviews with the patients who participated in the study to get their feedback about the whole process of starting dialysis. And what the patients told us was, well, you asked a lot of questions, but you didn't ask us about the fear of needles. And this was actually a major unaddressed issue. So we went on to do a prevalence study in all 700 plus of our dialysis cohort, which was a really major exercise, but has now set us up to be able to do really rapid point prevalence studies in our dialysis cohort quite quickly to answer various questions. And we found that 35% of patients who are receiving dialysis had a fear of needles at some point, and that it had a major impact on their treatment choices. So we're recognising that this was something that we hadn't fully appreciated or captured in our patient population. We then went on to do an audit of 12 months experience at the Royal Adelaide Hospital, Queen Elizabeth and at Flinders, looking at the experience of the first time new arteriovenous fistulas are needled. And we found that there was a high rate of trauma and failed needling that patients experienced, but also not only did the patients find that distressing and traumatic, but the nursing staff found it distressing and traumatic. So much of this work has now been published and helps us underpin the next things that we're doing. We've done a scoping review to see if there's any evidence base for interventions to help patients who are having repeated needling, and we've found that there's almost nothing in the literature that's proven to assist these patients. So we've got a big problem, but no way of dealing with it. We've then gone on to do some qualitative interview studies, both with nurses and patients, to try and identify some of the key factors that make needling go well, or that distresses both patients and nurses. And these have been really informative interviews that have helped shape our thoughts on what we need to do next to address this problem. We've now developed a nursing training module that's been co-designed with patients and nurses, and we're rolling this out in the next few weeks as a quality improvement project across all nurses within CNARTS. So every nurse is going to have this receive this training as a mandatory part of their CPD, and we'll be measuring the impact of that. And then finally, we have developed the INJECT intervention in collaboration with our psychology colleagues, and we're developing a screening tool to identify patients who've got needle fear. They get time with a psychologist as part of the intervention. There are some cognitive behavioural therapy modules that have been developed and a virtual reality component as well. Just to let you know that there's been consumer engagement at multiple stages of this whole process, and we have Luke McCauley, who is a consumer co-investigator and is actually doing his master's in health psychology based on a number of parts of these studies. So what we've been able to show is by this whole process, we've been able to go back and address that original feedback that we had from consumers that needle fear was a major unaddressed issue, and we hope to be able to give these patients some solutions coming into the future. So that was really just a quick overview of that project, and I just like to thank everyone who's been involved in the clinical research group, particularly our research coordinator that's supported by CNARTS, that's Richard Lalou. We have an executive that is multidisciplinary and really helps guide the work that we do. We have patient partners, particularly our Action Aboriginal Reference Group, and Luke and Sham, who have been very much involved in a number of these projects. We have a pregnancy consumer group as well, and they give a lot of time to help us develop these research ideas. We have a number of collaborators, and of course I'd like to thank all of the funding bodies, particularly Kidney Transplant Diabetes Research Australia and the Hospital Research Foundation and the Royal Adelaide Hospital Research Fund. So I might just leave it there, Randal, and take any questions.
Okay, thanks, Shilpa. Yeah, we've got a question from one of the attendees. Question is concerning patient partnering in the design of clinical trials. Can you elaborate the approach you are taking? Are you surveying patients in general or have a working group on certain themes?
Yeah, so I think one of the things that we've learnt doing a lot of patient partnering over the last few years is that you have to have really flexible models for how to involve patients. I think putting an individual patient onto a steering committee for a study doesn't really work. You've got to build relationships between the research group and the patients, and that organically develops over time. We've done it in a lot of different ways. I think having focus groups with patients and having that kind of involvement at the start of a project really helps you get your research question right. And then as time goes on, we've found that certain patients emerge as sort of champions or leaders and want to get more involved. And really at the other end of the spectrum, we've got people like Luke and Sham who are now co-investigators and equal research partners with us and undertaking research projects sort of semi-independently. So there's a spectrum of patient involvement, and I think it's really good up front as you start to talk to patients about your research to let them know that there's lots of different ways in which they can get involved.
Okay, thanks, Shilpa. So we've really come to the end of the time, but remind people that the sessions are available on the website. If you have any feedback, comments, please, you can enter them under the Q&A function as well for the next few minutes. And to remind people, the next Tuesday, the presentation is focusing on genomics with Dr. Peter Arts and Associate Professor Anna Brown, which will be chaired by Associate Professor Peter O'Loughlin. So thank you for joining us and see you next week. Thank you.